Good morning. Thank you all for being here, and thank you to Dr. Faries, Hamid, and Dr. Pirro for inviting me to speak to you this morning. So for the next 20 to 30 minutes or so, we're going to shift our focus to neoadjuvant and adjuvant therapies, a revolution in melanoma. So first, I think it's important to define some terminology and specifically what adjuvant therapy means. Adjuvant therapy is the administration of systemic therapy after surgery in patients with regionally advanced or metastatic disease. The goals of giving adjuvant therapy are really to provide durable local and regional control, to minimize functional deficits and morbidity for patients, and I think the most important is really to reduce the risk for distant failure. Historically, we can see that the overall survival for metastatic melanoma was actually quite poor, despite available systemic therapies. If you look at this graph, that you could see, on average, the median survival for patients with metastatic disease was in the order of 7 to 8 months. And for 3 decades, there were really no significant improvements in these numbers. Historically, interferon alpha in the 1996 to 2009 era was the best adjuvant therapy available. However, it was fairly ineffective with significant adverse effects. But approximately 10 years ago or so, the paradigm started to change. Clinical trials started to evaluate the efficacy of various checkpoint inhibitors and targeted therapies, predominantly in the stage 4 setting. And between 2015 and 2018, what we found in the advanced setting was transitioned to the use adjuvantly in patients with stage 3 melanoma. And here you can see some of the drugs that were approved between 2015 and 2018. Ipilimumab, which you may know as Yervoy, Nivo is Opdivo, dabrafenib and trametinib is Tafinlar, and Mekinist and Pembro. Thank you, Keytruda, the one that's posted everywhere on every commercial. And these were all FDA approved in the adjuvant setting between 2015 and 2018. So we're going to review some of the studies that allowed for approval of these drugs in the adjuvant setting. The first one was the EORTC 18071 trial, and this was a trial that allowed for FDA approval of ipilimumab in 2015. In this study, 900 patients were randomized in a 1-to-1 fashion to high-dose ipilimumab at 10 milligrams per kilogram every 3 weeks for a total of 3 years versus placebo. And this was given to patients with stage 3A, 3B, and 3C melanoma. In a majority of these studies, the primary endpoint was relapse-free survival, or recurrence-free survival, meaning how long did these patients survive without having any evidence of recurrent disease. And you can see here that the median recurrence-free survival for patients who received ipilimumab in the adjuvant setting was 27.6 months as compared to 17.1 months in the placebo arm, with a hazard ratio for recurrence of 0.76. So a hazard ratio essentially means if a hazard ratio is 3, that means that there's 3 times as much events occurring in the treatment arm, the study arm, as compared to the placebo arm. And if a hazard ratio of something is 0.3, that means you see 1/3 of that amount in the study arm, just to give you an idea. They also looked at overall survival, and again, there was a benefit with 5-year survival rates of 65.4% in the IPI arm, as indicated with the blue, as compared to 54.4% in the placebo arm, again with a hazard ratio of 0.72. This allowed for approval of IPI in the adjuvant setting. The next study was the CHECKMATE 238 study, and this was a study, again, looking at patients with completely resected, high-risk, stage 2B, 3C, or 4 melanoma. This is the only study that really included stage 4 patients who were completely resected before going on to therapy and didn't include stage 3A patients. These patients had BRAF V600E or K mutations, and essentially they randomized 870 patients in a 1-to-1 fashion to the previously mentioned dose of ipilimumab, high dose, 10 milligrams per kg every 3 weeks, versus nivolumab at 3 milligrams per kilogram given every 2 weeks. The primary endpoint, again, in this study was relapse-free survival. The other important thing to notice that all of these patients who were included in these studies, actually sentinel node positive patients, had to have had a completion node dissection. So these are not patients who had positive sentinel nodes and then underwent observation. And when looking at the relapse-free survival for these patients, again, you can see that the the patients in the nivolumab treatment arm did better than the patients in the ipilimumab arm, with 2-year recurrence-free survival rates of 63% in the nivo arm versus 50% in the ipi arm, with an impressive hazard ratio of 0.65. In this study, they also did a subset analysis looking at differences between patients with stage 3 disease versus stage 4 disease and found that this difference carried through. The stage 3 patients did a little bit better with a hazard ratio of 0.65 as compared to patients with stage 4 disease who had a hazard ratio of 0.7. But again, there was a benefit in both groups. The one really important thing that came out of this study was looking at the safety profiles of these two drugs. So you can see, if I know how to use this. Yeah, there it is. Okay. You can see this is the nivolumab arm, and essentially there were more adverse events in the ipi arm, grade 3 or 4 adverse events in the ipi arm, with about 55% of patients having grade 3 or 4 adverse events, as compared to the nivo arm, where only about 25% of those patients had grade 3 or 4 adverse events. And this was really important because when they evaluated and saw how many patients actually stopped therapy or discontinued therapy secondary to complications from the treatment drug, only 10% of patients in the nivolumab arm stopped treatment because of adverse events, whereas about 40% of patients in the ipi arms were not able to tolerate therapy and discontinued therapy at that point. Then we moved on to EORTC 1325, which was another study, this one evaluating pembrolizumab. In this study, again, they included high-risk resected stage 3 patients, so stage 3A, B, and C, and they randomized 1,000 patients in a 1-to-1 fashion to pembrolizumab, 200 milligrams, given every 3 weeks over the course of a year, versus placebo. What's interesting in this study is in the placebo arm, if they saw recurrence after 6 months occurring, the patients were able to be unblinded and transition to getting pembrolizumab for treatment. And again, the primary endpoint of the study was recurrence-free survival. Here you can see that at a period of 1 year, so if you look at 12 months, right here, the patients in the treatment arm receiving pembrolizumab had a 75.4% recurrence-free survival rate as compared to 61% in the placebo arm, with an impressive hazard ratio of 0.57. And this trend really carried through to 18 months and beyond. They also did a subset analysis, and not surprisingly, patients with stage 3A disease did even a little bit better than the other groups. And overall survival analyses are still pending and not yet available from this study. So that really covers the use of the majority of the immune checkpoint inhibitors that have been approved thus far for adjuvant in the adjuvant setting for melanoma. And now we'll speak a little bit about targeted therapy for the BRAF mutated patients. So the COMBI-AD study is the one major study that looked at dabrafenib and trametinib versus placebo, again in stage 3 resected melanoma patients. The criteria for inclusion in this study included completely resected high-risk stage 3 patients. They had to have BRAF V600E mutations or K. They had to be surgically free of disease for at least 12 weeks before enrollment. And they were randomized in a 1-to-1 fashion to the dabrafenib twice daily plus trametinib once daily arm for a period of 12 months versus placebo. The follow-up that they described at the end of the study, or the study end, was really defined to be considered complete and final in terms of overall survival analysis once 70% of the patients who were included in this study either relapsed and died from disease or were lost to follow-up. So primary endpoint, again, was relapse-free survival. And you can see here that there's a major separation occurring quite early, and that by 12 months, there's still a large difference that exists between the two arms. The median relapse-free survival was actually not reached in the BRAF MEK arm, and in the placebo arm, the median relapse-free survival was 16.6 months, with a hazard ratio of 0.47 favoring the treatment arm. When looking at distant metastasis-free survival, again, there was a significant benefit. neither the dabrafenib trametinib arm or the placebo arm reached the median distant-free metastasis survival time point. However, there was a hazard ratio of 0.51 in favor of the treatment arm. Now, if you remember, I told you that the overall survival analysis was deemed to be not accessible until 70% of patients had succumbed to disease or were lost to follow-up. However, in this fairly early analysis, you can see that there is a benefit in the dabrafenib trametinib arm with improved overall survival rates at 1, 2, and 3 years when compared to placebo with a hazard ratio of 0.57. However, given that this was an early analysis and didn't reach the significant boundary that was predefined, it has not yet been declared positive for overall survival. It's an outcome of this study. So what do we know about the adjuvant therapy of melanoma at this point? Well, interferon and ipilimumab are no longer recommended in the adjuvant setting. Interferon is not quite as effective as everything we have available, and ipilimumab has pretty significant toxicities. So the current adjuvant treatment options are nivolumab or pembrolizumab for all patients, BRAF mutant and wild type, or nivolumab and pembrolizumab, or dabrafenib and trametinib for BRAF mutant patients. Despite the fact that we have these treatments available, we should always consider our patients for clinical trials, and you should always ask your doctors if there's clinical trials available in which you can participate. So the next question is the next step to provide neoadjuvant therapy to patients plus minus adjuvant approaches, and is that going to be the next advance in melanoma treatment? So again, to define what we mean by neoadjuvant therapy is the administration of systemic therapy prior to surgery in patients with accessible, regionally advanced, or metastatic disease, with a plan to carry out resection of the tumor after a defined period of time. This might be a little bit different than upfront therapy in patients who are unresectable or maybe borderline resectable. These are patients in whom we plan to carry out surgery definitively. When we say accessible, regionally advanced, or metastatic disease, we mean that by giving you treatment, we're able to actually assess the response of the tumor to the neoadjuvant therapy with which we're providing, and we can do that either radiographically through CT imaging, metabolically, maybe through a PET, or histologically, maybe through biopsies, or at the end of surgery by assessing how much response you've had once the tumors have been removed. And the thought here is that post-operative adjuvant therapy may or may not be used, and its use can be mandated or considered based on the response to the neoadjuvant therapy. So what's the track record for neoadjuvant therapy in melanoma? Well, compared to what we know in other solid tumors like breast cancer, bladder cancer, esophageal cancer, rectal cancer, pancreatic cancer, gastric cancer, we're a little bit behind. So in those other solid tumors, we've seen significant improvements in overall survival, surgical resectability, local control, and organ preservation when giving patients neoadjuvant therapy followed by surgery. In melanoma, however, the experience is still small. Mostly, we have some small phase 2 single institution trials that we'll discuss briefly. And really, there's only been a few regimens with high enough response rates and survival impact in the stage 4 setting to suggest that we should study these in the neoadjuvant setting. What are the potential benefits? Why are we even considering neoadjuvant therapy? Well, it could provide us with an objective measure of a patient's response to treatment, which may result in a personalization of adjuvant therapy. So if we give you a drug and you have an excellent response, then we know once we remove the tumors and we give you the same drug, you'll probably, if you have any micrometastatic disease that's not visible, that drug should work. However, if we give you a drug and you have no response to that therapy, then that's probably not what we would give you in the adjuvant setting. It can reduce the tumor burden before surgery. That could allow for better regional disease control. It may make borderline resectable or unresectable patients resectable, so kind of this concept of upfront therapy turning into neoadjuvant therapy potentially. It may allow for more effective treatment of distant micrometastatic disease. So if we think that these immune therapies work by the mechanism of activating T cells, What's potentially important is that giving these drugs in the context of a lot of tumor antigen can make them more effective in the adjuvant setting because they see more tumor up front. And lastly, it can allow us to understand tumor biology and identify new targets for therapy. So one study out of MD Anderson was the first randomized study of neoadjuvant therapy versus standard of care. Standard of care is the upfront surgery with the consideration of adjuvant therapy. This was done in patients with high-risk resectable BRAF mutated melanoma, so again, your stage 3 patients. And essentially, it randomized patients in a 1-to-2 fashion, favoring the treatment arm, to either upfront surgery and consideration for adjuvant therapy or neoadjuvant dabrafenib and trametinib, followed by surgery, followed by adjuvant therapy. What they found between 2014 and 2016, they assigned 7 patients to the standard of care arm, meaning they received therapy adjuvantly after surgery, and 14 patients to the neoadjuvant arm. What happened is the trial actually stopped early after an interim safety analysis. So the interim safety analysis was mandated once they had accrued about a quarter of the patients to the study. And upon doing that analysis, they saw that there was a significantly longer recurrence-free survival in the neoadjuvant arm as compared to the standard of care arm. You can see that the median event-free survival in the neoadjuvant arm was 19.7 months, whereas in the standard of care arm, it was about 3 months, with a hazard ratio of 0.016. When they looked at neoadjuvant therapy and its impact on response, these patients all had evaluable radiographic responses, and 13 out of the 14 patients actually had an overall radiographic response after neoadjuvant therapy. 2 of these patients had complete responses, meaning we could no longer see the disease, and those are indicated in the purple. 9 patients had partial responses, and 2 patients had stable disease, which is pretty impressive. There was also an overall survival benefit with a hazard ratio of 0.28. So in good conscience and seeing such a tremendous benefit with neoadjuvant therapy, this study was changed to a single-arm trial, evaluating only neoadjuvant therapy, followed by surgery, followed by adjuvant therapy. Another study is the OPASSIN trial, which is from the Netherlands. And this is a neoadjuvant versus adjuvant checkpoint inhibition trial looking at IPI plus Nivo, again in stage 3 melanoma. This includes patient with stage 3B and 3C disease. And the 2 arms are the adjuvant arm, which patients receive surgery, followed by IPI at 3 mg per kg, and Nivo, versus the neoadjuvant arm, in which patients receive 2 cycles of IPI plus Nivo, followed by surgery, followed by an additional 2 cycles of IPI and Nivo. So the data we have thus far is median follow-up of 17 months. There was 10 patients only that were randomized to each arm. With respect to pathologic response rates, in the neoadjuvant arm, about 80% of patients had pathologic response with 3 complete responses, again meaning that all disease disappeared. 5 patients with near complete responses. 2 out of 10 patients in the neoadjuvant arm thus far have relapsed, 1 with distant disease and 1 with local disease. And 3 out of 10 patients in the adjuvant arm have relapsed, all with distant recurrences. This was also a phase 1b feasibility study to look if patients can actually tolerate the IPI and Nivo. And they identified that there was 90% of patients who had grade 3 and 4 adverse events in both arms. It didn't matter if you were receiving it neoadjuvantly or adjuvantly, and only 2 out of 20 total patients actually received all 4 courses of treatment. All the patients in the neoadjuvant arm did undergo surgery at the pre-planned time point, and further data from this trial are still pending. So what are the pros and cons of neoadjuvant therapy versus adjuvant therapy? Well, adjuvant therapy, we know the exact stage of disease when treatment begins. The patient has generally recovered from the acute complications of surgery, so any adverse effects of treatment cannot really negatively impact planned surgery. What about neoadjuvant therapy advantages? We talked about some of them, but again, the positive effects of treatment can make surgery easier, less morbid, or more effective, and sometimes can even yield surgery unnecessary, as Dr. Ferries alluded to as a possibility of the future. And the response to therapy can really be assessed, and postoperative therapy can be adjusted accordingly. So what is the potential next melanoma revolution? Well, I think we're all moving towards providing the right care to the right patient at the right time, so personalized medicine, essentially. The important questions that remain to be answered are, which treatments should we provide first, and for how long? For example, in these BRAF mutated melanoma patients, should we be giving Nivo or Pembro, or should we be treating them with BRAF and MEK inhibitors? Who does better and why? How much drug is enough? What's the durability of benefit? What are the less fatal toxicities? Should we be giving these drugs neoadjuvantly, and if so, which drugs? What is the role of neoadjuvant therapy for patients who present with bulky resectable disease? Should we be considering upfront therapy in borderline or unresectable patients with consideration for surgery should they have good responses? And I think it's important for all of us to remember that we have to have a continued knowledge of what studies are currently pending, and I know our experts, Dr. Hamid Davies, will be discussing this a little bit more. So with that, thank you.